If you're listening to this podcast on YouTube, for a better experience, switch to the video version. The link is in the episode description. Hello and welcome. I'm Fernando, AGP in the UK. In today's episode, we'll look at the NICE updates published in July 2026, focusing on what is relevant in primary care only. This month, we have 3 areas to cover: updated guidance on low back pain and sciatica, updated guidance on heavy menstrual bleeding, and a brand new guideline on osteoporosis risk assessment. Right, let's jump into it. Let's start with osteoporosis risk assessment. NICE says to assess fragility fracture risk in all people aged 50 and over and in women who have experienced menopause, either have had a previous fragility fracture or currently use or frequently use systemic steroids. It also says to consider assessment in all men aged 75 and over, all women aged 65 and over, and younger people with risk factors. These include 2 or more falls in the last year, hip fracture in a first-degree relative, BMI below 18.5, smoking, alcohol intake over 14 units per week, and other risk factors such as, for example, endocrine or gastrointestinal conditions, multiple myeloma, Parkinson's disease, immobility, COPD, autoimmune disease, and CKD stage 4 or 5. For people under 50, the threshold is higher. We should assess risk after a previous hip or vertebral fragility fracture, 2 or more major osteoporotic fractures, or another major risk factor. For people aged 40 to 90, we should use FRAX or Q fracture to estimate 10-year major fracture risk. For people aged 30 to 39, we should use Q fracture. For people over 90, we should remember that FRAX assumes age 90, while Q fracture calculates risk up to age 100. We should seek specialist advice for people under 30 or with rare bone diseases. We should offer DEXA scan to people aged 30 and over with a previous hip or vertebral fragility fracture, a single major osteoporotic fragility fracture in the last 2 years, or 2 or more fragility fractures. We should also consider a DEXA scan where the 10-year fracture risk is 10% or more. When starting treatment, we should usually do a baseline DEXA scan unless it is not tolerated or feasible. If DEXA is delayed, we should consider fast tracking within 6 weeks if anabolic treatment is likely, or starting anti-resorptive treatment if anabolic treatment is unlikely. NICE also discusses DEXA-based vertebral fracture assessment, or VFA. What is VFA exactly? VFA is an extra spine image done using the DEXA scanner to look for vertebral fragility fractures. We should consider VFA in men aged 70 and over and women aged 60 and over. In younger people, we should consider VFA during DEXA if there has been a previous major osteoporotic fracture, signs or symptoms of vertebral fracture, systemic steroid use, or exceptionally low bone mineral density for their age. For treatment decisions, we should consider FRAX or Q fracture risk scores, DEXA results if available, previous fragility fractures and risk factors. For people aged 50 and over and women who have experienced menopause, we should consider treatment after a previous hip or vertebral fragility fracture or high-dose systemic steroids. We should also consider treatment with a T-score of -2.5 or less, or -1.5 or less if there is previous fragility fracture, systemic steroid use, or other risk factors. Treatment can also be considered without DEXA scan if the person meets assessment criteria but DEXA scan is not tolerated or feasible, for example in frail older people. If someone declines treatment, we should advise when and how to access the service if they change their mind or circumstances change. If 10-year risk fracture is below 10%, we should reassess if circumstances change or at 5 years. If 10-year risk fracture is 10% or more, or DEXA scan was done but treatment criteria were not met, we should do the same, but consider repeating DEXA scan within 2 to 3 years if they were close to treatment criteria. Now let's move to low back pain and sciatica. In this update, NICE has withdrawn the recommendation on psychological therapy and combined physical and psychological programs for low back pain or sciatica. The rest of the primary care approach is largely unchanged. We should think about alternative diagnoses, including red flags, cancer, infection, trauma, and inflammatory disease. Management may involve exercise programs with or without manual therapy. We should not routinely offer imaging. If referring, we should explain that imaging may still not be needed and that imaging should only be considered by a specialist if it is likely to change management. For self-management, we should encourage normal activities and consider group exercise programs for suitable patients. Manual therapy, including manipulation, mobilization, or massage, can be considered only as part of a package that includes exercise. For medicines, NICE says not to offer gabapentinoids, other antiepileptics, oral steroids, benzodiazepines, or opioids for low back pain and sciatica. If prescribing non-steroidal anti-inflammatory drugs, we should consider gastrointestinal, liver, and cardiorenal toxicity, age, and other risk factors, and use the lowest effective dose for the shortest possible time. Weak opioids, with or without paracetamol, can be considered for acute low back pain only if non-steroidal anti-inflammatory drugs are contraindicated, not tolerated, or ineffective. But NICE says not to offer paracetamol alone for low back pain. It also says not to routinely offer opioids for acute low back pain and not to offer opioids for chronic low back pain. Finally, let's look at heavy menstrual bleeding. The update is about serum ferritin testing. Previously, NICE advised not to routinely test serum ferritin in women with heavy menstrual bleeding. That recommendation has now been removed because of the risk of iron deficiency. Heavy menstrual bleeding can have a major impact on quality of life, and management should focus on this rather than blood loss alone. If there are no related symptoms, NICE says we can consider pharmacological treatment without physical examination. However, we should offer examination if there is intermenstrual bleeding, pelvic pain, pressure symptoms, or if considering a levonorgestrel releasing intrauterine system. We should do a full blood count and use clinical judgment on ferritin. We should consider coagulation testing if heavy bleeding has been present since period started and there is a personal family history suggesting a coagulation disorder. We should not do female hormones or thyroid testing unless clinically indicated. We can start pharmacological treatment without investigating if history or examination suggests low risk of uterine or histological abnormality. If cancer is suspected, we should follow the NICE suspected cancer pathway. If investigations are needed, we should use history and examination to decide between hysteroscopy and ultrasound as a first-line investigation. We should offer outpatient hysteroscopy if the history suggests submucosal or endometrial pathology. For example, if there is persistent intermenstrual bleeding or risk factors for endometrial pathology. However, we should offer pelvic ultrasound if the uterus is palpable abdominally, a pelvic mass is suspected, or examination is inconclusive or difficult. For suspected adenomyosis with significant period pain or a bulky tender uterus, we should offer transvaginal ultrasound in preference to transabdominal ultrasound or MRI. For no identified pathology, fibroids under 3 cm without cavity distortion or suspected adenomyosis, we should consider a levonorgestrel releasing intrauterine system first. If this is declined or unsuitable, we should consider tranexamic acid, non-steroidal anti-inflammatory drugs, combined hormonal contraception, or cyclical oral progestogens. Progestogen-only contraception may suppress menstruation, which may also help. We should refer if treatment is unsuccessful, pharmacological treatment is declined, symptoms are severe, there are submucosal fibroids, or fibroids are 3 cm or more. While investigations or definitive treatment are being organized, tranexamic acid and non-steroidal anti-inflammatory drugs can still be offered. So that is it, a review of the NICE updates relevant to primary care. We have come to the end of this episode. Remember that this is not medical advice, but only my summary and my interpretation of the guidelines. You must always use your clinical judgment. Thank you for listening, and goodbye.